Then there was retrospective data which looked at patients with oligometastatic lung cancer, saying first, do those patients exist? And yes, they do. They represent about 7% of all lung cancer patients, which is relatively rare, but if you think about it, it's about the same as ALK, right? So this is a population with needs. So how do we treat these people? We've seen in some retrospective series that doing what we would call locally ablative therapy, so radiation, surgery to everything you can see, leads to better outcomes compared to historical control. And more recently, there have been multiple randomized controlled trials that have shown that, yes, if you have limited oligometastatic disease, giving locally ablative therapy leads to better progression-free and overall survival. There are limitations to those trials. They're phase 2, they're relatively small, and there are some issues in terms of cherry picking. But what we're clearly seeing is that there does seem to be an advantage to adding this form of treatment. Exactly how to incorporate it into modern medical care, I think, is still an unanswered question. There are ongoing phase 3 studies to confirm the findings of those randomized phase 2 studies, but it's going to take some time. And I would urge treating physicians and providers to not jump to the oligometastatic locally ablative therapy for all persons, but to consider it, to say, well, here's the data, here are the limitations of it, and does this make sense for the patient in front of me?